Good afternoon and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. Any financial relationships of the planners and speakers have been mitigated. If you have a question for our presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A section. Also, a link to the event survey will be shared at the end of the program. It is now my pleasure to introduce our guest speaker, Dr. Cinsley Gentillon. Originally from Haiti, Dr. Gentillon has proudly made Georgia her second home. She earned a Master of Science in Biological Sciences from the University of Delaware before completing her medical degree at Ross University School of Medicine. In 2023, Dr. Gentillon returned to Georgia to pursue an internal medicine residency training at Northeast Georgia Medical Center. She will continue her training as a nephrology fellow at Emory University School of Medicine beginning in July. Please join me in welcoming Dr. Gentillon.
All righty, thank you everyone for coming in today to hear about focal segmental glomerulosclerosis from podocyte injury to precision therapy. Today's learning objectives are as follows. We'll be defining focal segmental glomerulosclerosis or FSGS, understanding its pathology, distinguish the different types and histopathological variants of FSGS, recognize its clinical presentations. We'll highlight diagnostic approaches and evidence-based management of FSGS, and we'll review the overall prognosis of FSGS and discuss what to do when it reoccurs. We'll reinforce some key concepts with 2 clinical vignettes, and in the end, summarize key home points. Now, remember in medical school and a lot of the medical review books, FSGS is actually categorized under nephrotic syndrome, which is true, but there's more to it. FSGS is actually defined as a morphologic pattern of glomerular injury, and it's usually visualized under light microscopy. And what do we see? We see scarring or sclerosis of parts of the glomerular capillaries, and that sclerosing then leads to accumulation of extracellular matrix in some of the glomeruli, hence the name focal segmental glomerulosclerosis. Now, why am I giving this talk today? Well, FSGS is actually a very important disease. It's a major cause of nephrotic syndrome. It's the leading glomerular cause of end-stage renal disease, or ESRD. That accounts for about 40% in adults and 20% in children, which is pretty high. And once individuals are diagnosed of FSGS, if they're not properly managed, then they can actually, it said 50% of them can actually progress to ESRD within the first 5 to 10 years of diagnosis. In the recent years, FSGS is actually has an increasing incidence worldwide. It accounts for about 0.2 to 1.8 per 100,000 individuals worldwide. And in the US, it actually accounts for 35% of all nephrotic cases. Certain populations are more prone to FSGS, including male and individuals of African ancestry. Now, what is the pathophysiology of FSGS? I'm not going to go in detail in renal physiology. We'll be here forever. But we all remember that one of the key function of kidneys is filtration, and that occurs in the glomeruli located at the end of the nephrons. If we take a closer look at all the cells that play a factor in glomerular filtration, the podocytes, which are the epithelial cells, are the key ones, and they sit on the basement membranes, and they're interlinked together, forming the podocyte fruit processes. Now, in FSGS, they're actually the ones that are targeted, and when they get injured, some of them get injured, the ones that are not injured, then they compensate for that by proliferating and hypertrophying. And other cells around the podocytes also get affected, including the mesangial cells, the endothelial cells, and other epithelial cells, and they proliferate as well. And what happens with all this injury and compensation, then you get flattening of that nice podocyte fruit processes, which is called effacement, and leading to the loss of really major proteins that are important in the body, including albumin. And also we see a major collapse or shrinkage of the capillaries around the glomeruli. Now, FSGS is really differentiated into 4 different types, which is really important in terms of treatment, which we'll talk about later on. And those types are primary, secondary, genetic, and FSGS on undetermined cause. Primary FSGS, or just idiopathic, is actually what we all see in textbooks and what we all know under nephrotic syndrome. It's said to be caused by autoantibodies or permeable factors that attack the nephrons. So one of the major autoantibodies that they've discovered a while ago called anti-nephrin. Nephrin is actually one of the proteins that we find in the sleeve diaphragm between the podocytes that hold them together so that important proteins don't get sieved through the glomerular basement membrane. Now, in primary FSGS, it's pretty extensive. If you were to take a kidney that's affected by primary FSGS, you would see more than 80% of the food processes are affected. They're flattened. And you also see massive, because of that massive injury, you also see a lot of hyaline deposit under the glomerular basement membrane, and it loses its integrity, loses major proteins, and also a lot of narrowing of the capillary lumen. I have example here. On top, we have a normal glomerulus. We have that nice basement membrane here, and the podocyte food processes on top holding that integrity versus glomerulus that is impacted by primary FSGS. You can hardly make up the glomerular basement membrane. It's just collapsed. And here in the asterisk is just the hyaline deposit. And here with the arrows, the narrowing of the capillary lumen. As I said, primary FSGS is what we see in textbooks. So clinical features, pretty abrupt onset of nephrotic syndrome, which is high-grade proteinuria classified by more than 3.5 grams per day. That results in massive periorbital and peripheral edema, weight gain. Also for vitals, you would see high blood pressure. Lab-wise, you would see low albumin. You'd see high cholesterol that can deposit into the skin, causing xanthomas. If you did a UA, you would also see red blood cell casts. And also, because the kidneys are impacted, then you would see a rise in the BUN and creatinine as well. Secondary FSGS is what we don't really hear about. That's very different than primary FSGS. It is thought to be an abnormal response to the injury to the podocytes. It's not caused by the autoantibodies that I mentioned before. Instead, it's caused by secondary factors, which I'll elaborate more in the next slides, and those include viruses, drugs, toxins. And if you were to take a kidney biopsy, look at it under light microscopy, it's really different than primary FSGS. You would see it's less extensive. You see less than 80% effacement of the podocyte food processes. Now, to really understand the secondary causes of FSGS, you have to look at groups. Either you have normal renal function, and the leading causes for those are obesity usually, hypertension, even sickle cell anemia and diabetes. In terms of more congenital, either you have renal agenesis or a nephrectomy that could lead to that as well. Drug-induced, some of the most common ones that we use, bisphosphonates in clinic, steroids as well, and lithium can also cause secondary FSGS as well as heroin. In terms of viruses, HIV is a common one that can cause FSGS, and it's usually aggressive. CMV, hepatitis C as well. And I wanted to mention, we do know COVID can lead to a lot of things, and there's been a lot of case reports that link COVID to secondary FSGS as well in the recent years. So given that it's not as extensive as primary FSGS, secondary FSGS is more gradual in progression. You often don't see the nephrotic range of proteinuria. It's usually less than 3.5 grams per day. And if you were to look at the labs of someone impacted by secondary FSGS, you'd see normal, sometimes even higher serum albumin. Because the albumin is normal, you don't have that massive periorbital peripheral edema. The only exception that I've seen in literature in terms of secondary FSGS that presents like primary is the collapsing HIV-associated nephropathy, because it's a more aggressive one. In terms of the two other major types of FSGS, genetic FSGS is usually caused by mutations of genes that play a role in podocyte function, as well as the integrity of the glomerular basement membrane. In childhood onset genetic FSGS, usually autosomal recessive, present with severe nephrotic syndrome like primary FSGS. Adult onset genetic FSGS is it's more benign, but it's usually autosomal dominant and more slowly progressive. And because of that, the different variants in the mutation and expression, then you see a wide range of clinical features that's usually a mix of primary and secondary FSGS. Now, like in every science, if you don't really know what something is, then it's unknown. So that's why the FSGS of unknown cause, that is if you've already ruled out primary, secondary, and genetic, then you really don't have a clear etiology, but it has a clinical finding of FSGS on light microscopy, then it falls under that criteria. And the features that I've seen in literature, as well as what the clinical features in the findings of microscopy, are very similar to secondary FSGS, meaning less than 80% of podocyte effacement. For genetic FSGS, I had a separate slide because there are thousands of genes that have been proposed to be involved in genetic FSGS, but I wanted to highlight three. First, the three are very common ones. The NPHS1, which encodes nephrin. We have the Wilms tumor protein as well, and the laminin beta-2 chain. The last one I highlighted here, the apolipoprotein L1, is on the rise in 2010, actually. First of all, apolipoprotein L1 is known to play a major role in innate immunity, but in 2010, they did these research where they looked at a lot of people with genetic FSGS, and a lot of them overexpress a mutation in apolipoprotein L1, and it was an aggressive type of FSGS that they developed. Although they have done extensive research, its function in the kidneys is actually unknown for now. Given that, it looks like there's a lot of cross variants in the 4 types of FSGS, which is very confusing. So in 2004, they actually came up with subtypes of FSGS using the Columbia Association that further subdivide the FSGS into 5 different groups, and they're very what you see under the histological pattern is very similar to what the title is. TIP, you see you usually see the injury on the outer portion of the glomeruli. It's usually, the clinical features are very similar to primary FSGS. Cellular is just proliferation of different cells in the center of the glomerulus. This one is tricky because you have to actually rule out the other subtypes before you can present that someone has the cellular variant. Perihilar, the injury is around the perihilar area of the glomerulus, and this one is more, associates more with the secondary type of FSGS. And collapsing is one that is very severe. It has a very poor prognosis. The extent of the injury is so severe that you can hardly make up any of the integrity of the basement membrane. And this one is actually one that it has been linked to mutation is APOL1, and also, as I mentioned before, the HIV-associated nephropathy is also a collapsing variant. Then again, even in the subtypes, there's also some unknown. So if you've ruled out all the other ones, then there's still the not otherwise specified that really doesn't fit into the others, and that's actually one of the most common subtype of FSGS. Now, in terms of clinical assessment, as we all know in medicine, a good history and physical is important. Being able to see if someone has nephrotic syndrome in terms of peripheral edema, periorbital edema, there's some key questions you can ask when you're actually seeing a patient include their overall medical history, what medications they're on, any drugs that they've done, any family history of inflammatory diseases. Also, pay attention to their body mass index, and a good physical exam to, like I said, to rule out nephrotic syndrome is important. Now, if you've done this and there's really some concern for FSGS, some basic labs we can do, obviously we all do the CMP, we look for the renal function, pay attention to albumin, low versus normal is really important in differentiating between the different types of FSGS. Urinalysis will show you if there's red blood cell cast present. And lipid panel can also help you in terms of abnormal cholesterol level. But even then, although that's important and that can kind of target you, do I need to get a specialist on board? And if you do have that high suspicion, then yes, you do need to get a nephrologist on board, because the key diagnostic tool for FSGS is a kidney biopsy. I found this algorithm to be really helpful, because if, like I said, differentiating between the types is really important. So even if they did a kidney biopsy, you still need to kind of go back and figure out, well, on the labs and physical exam, the overall picture, is there nephrotic syndrome present? If there is, then on the slides, is there more than 80% of podocyte food process effacement? If yes, then that's definitely confirmed primary FSGS. But if not, then you have to go back to your history and physical, find out, are there any other secondary causes of FSGS? Because that's important, because if there's none that you can find, then the next step is genetic testing. And if there's no nephrotic syndrome, it's the same algorithm as well. You go back and look at the foot process effacement, more than 80%. It's usually, that's not really primary, because usually primary comes with nephrotic syndrome, so that one warrant genetic testing as well. And if it's less than 80%, then again, you rule out secondary causes, and if there's none, then consider genetic testing. For all of the FSGS, in terms of management, supportive care is important in terms of some things that you can modify, or you can help the patient modify, include weight loss, smoking and alcohol cessation. If blood pressure is an issue, make sure you target that. Make sure they have dietary sodium restriction as well. And in terms of blood pressure, if there are medications that are not renoprotective, meaning the ACE, ARB, or SGLT2, then make sure you can optimize those medication, because they're ACE, ARB, and SGLT2 have been shown to actually decrease proteinuria in renal patients. If they have high lipids, statin is important. And one thing I wanted to mention is patients with nephrotic syndrome, they are at high risk of clots, because remember that they're losing a lot of proteins in the kidneys, so that triggers the liver to produce more, start the clotting factor, and that puts them at risk to develop clots in the future. Now, in primary FSGS, the first line of treatment is actually steroids. Usually you start at 1 mg per kilogram, and the maximum dose for that is usually 80 milligrams per day. But you have to at least do it for 4 weeks before the patient can feel a difference. And the mistake people have made is just reassessing the patients too soon. Once you start steroids, you have to wait at least 16 weeks before you can assess them for remission. And even if they actually achieve remission, you have to continue steroid therapy for at least an additional 2 weeks to prevent relapse of the disease. If they're intolerant of steroids, or you need an alternative, maybe they're pregnant or other things, then calcineurin inhibitors have also been used, also safe in pregnancy, cyclosporine cyclosporin and tacrolimus are the ones that are commonly used for primary FSGS. The only thing is we have to be cautious if the patient has an GFR less than 30. These molecules can actually be nephrotoxic, so they won't be able to clear them. However, the calcineurin inhibitors, while they're not first line, they take a bit longer to work because they have to build up in your system, about 4 to 6 months before you can reassess the patient for remission. And usually they have to stay on these agents for a longer term before you can start tapering them off, usually 12 months to prevent relapse. Other treatments that can be used in FSGS include other things like mycophenolate, high-dose dexamethasone, and rituximab, and also ACTH because it stimulates the pituitary to release more steroids. Now, let's say that you've done all the treatment necessary, and you did the right length of treatment, but somehow they end up having the disease again, or relapse, or even resistance to the treatment, then you'd need to do a genetic testing at that point to figure out if you've missed anything else. And at that point, most specialists also rebiopsy the kidney if they failed treatment or become resistant to treatment. And as I said in the beginning, FSGS is progressive. It's pretty severe. It can be pretty severe. So you have to monitor those patients closely because they can progress really rapidly, and you have to make sure you give everyone a chance and evaluate them for renal transplant early on in the disease process. And for secondary FSGS, as we saw the different causes, we always want to make sure there are no drugs or toxins that could be causing it, other viral infections, or other stressors like obesity, hypertension that can cause that as well. With treatment of FSGS, really, your target is complete remission. And how do you monitor that? It's usually by your urinalysis, and you look at protein creatinine ratio to look at the degree of proteinuria. For example, if they came up with a protein range of 3.6 gram per day, so you would monitor them pretty closely, usually every 1 to 2 weeks, to look at the urinalysis, and the goal is less than 300 milligram per day. And also you want to look at the serum albumin. Most often they have low albumin, so you want to increase that to over 3.5 per day. And also make sure that their serum creatinine is stable. Anything that does not meet that criteria I would consider partial remission, so they would have to continue for a longer course of therapy. And even if they have been treated for the right amount of time with the right agents, they can actually relapse, and you would see the same pattern that you've seen before in the disease. And just for steroid-resistant FSGS, you can't really label it that unless you have adequately treated the patient for 16 weeks, and they have not responded to that. And for the calcineurin inhibitor-resistant FSGS, you have to treat them for more than 4 to 6 months. Now, there are a lot of emerging therapies in FSGS because medicine is trying to move into more precision therapy for that disease, given a lot of antibodies, a lot of genes are involved in the disease process. Actually, last month, the FDA actually approved sparsentan to decrease proteinuria in FSGS. I think it was also approved for IgA nephropathy as well, and safe in children above 8 years old as well as adults. Sparsentan works as antagonist of endothelin A and angiotensin II. There are other ones as well, all the bottom ones, they're still in clinical trial right now. Another similar one that's right behind sparsentan is atrasentan, and that one works as an antagonist of endothelin A. And in terms of more precision therapy, they're looking at other small molecules that inhibit JAK-STAT and other proteins that are expressed on the podocyte and glomerular basement membrane. Those are also still on clinical trial, and there was also the ones that target apolipoprotein 1 as well. And then the last one I've seen more recently is the coenzyme Q10 that works at the level of the mitochondria to reduce reactive oxygen species. Now, if I haven't convinced you enough, I just wanted to let you know that FSGS is really important. It's actually a chronic progressive disease with pretty poor prognosis in some cases. Just wanted to reiterate again, if someone is not properly diagnosed, or even if they're diagnosed properly but not being managed as they should, then 50% of these people can actually progress into ESRD within the first 5 to 10 years of their diagnosis. Primary FSGS, as severe as we saw with the more than 80% of podocyte food processes, actually has a poor prognosis compared to the other types. Genetic FSGS really depend on which variant. If they have a genetic in the apolipoprotein 1 is actually one of the poorest ones. And your key is remission, because remission is actually associated with a 5-year survival of dialysis of about 94% compared to 53% of individuals who have not achieved remission. So that's a pretty big difference, and that's something to keep in mind when we come into contact with someone with FSGS. Now, let's say someone had primary FSGS, they were treated, did well for some time, and the disease came back, did really poor with all the therapies, and they ended up getting a new kidney. Can they get FSGS again? The answer is yes, which is really unfortunate, because it's pretty aggressive. Now they have a kidney, and now they're about to lose that one too. And that's called recurrent FSGS. And usually they present with the same symptoms, the symptoms that are similar to primary FSGS, and the morphological findings on electron microscopy is also similar to primary FSGS. I was looking at different research. It looks like it's pretty high, the recurrence rate of post-transplant FSGS. It's about 32%, pretty alarming. And a lot of them, it looks like the risk factors that predispose them for recurrence include if they were older age at the time that they had a kidney transplant, being Caucasian, also high BMI at the time of transplant as well. And again, we go through the same algorithm in terms of the labs we would order. And for key diagnostic tool is the allograft biopsy. When a patient has recurrent FSGS, the management is actually different than the other types. Usually, and monitoring is also different. You have to, after they get a new kidney, it's pretty extensive. You have to monitor daily creatinine and urine protein. You monitor for proteinuria for about a week. Then you would do that twice weekly and 2 weeks after, and weekly for 4 months, monthly for a year, and every 3 months thereafter. As I said, because 32% of them can actually have recurrent FSGS. And the therapies are slightly different as well. Plasmapheresis is usually used, and immunoabsorption therapy. And also they use more precision medicine as well in recurrent FSGS, including the anti-CD20 monoclonal antibodies. Things that I wanted to highlight in the talk is that not all FSGS are the same. So why do we need to understand differentiate primary, secondary versus genetic? Is because that will impact the overall treatment of the disease. Primary responds well to steroids and calcineurin inhibitors versus secondary. If you take away the secondary cause, most likely they will recover. And genetic, with all the precision therapy on the rise, that's really important to understand as well. And a lot of the time, if therapy started, not allowing the patient to be on therapy for sufficient time is also one of the key pitfalls that I've seen in practice. And apolipoprotein 1 is also on the rise, and it's pretty aggressive, really high risk, and really high in patients of African descent. And a lot of new therapies on the rise as well for apolipoprotein 1. And ignoring proteinuria trajectory as well is another key pitfall, because you want to know that early on to see if they need a renal transplant or not. So I know I talked a lot, but this is a fun portion of the talk. I just wanted to go ahead and give you guys a chance to learn more via questions. I can go ahead and read the first question for you guys. 38-year-old man is evaluated during a follow-up visit for pulmonary chronic kidney disease. Family history is significant for end-stage kidney disease in 2 uncles and a female cousin. He has no other medical problems, and his only medication is lisinopril. The patient is of African descent. On physical exam, vital signs are normal. There are features of generalized anasarca with marked edema of the lower extremity. The remainder of the examination is unremarkable. The labs that they've given us, we have low albumin, high cholesterol of 264, high creatinine of 1.8, urinalysis 4+ protein, and the urine protein creatinine ratio about 78/50. Which of the following is the most likely diagnosis? A, FSGS, B, lupus nephritis, C, membranous nephropathy, D, minimal change disease. I know my talk is about FSGS, but it could also be something else. What do we think?
What do we think? We're going to go A.
Okay, sounds good. So that was pretty straightforward, but I just wanted to highlight when you're reading those questions what to think about, or when you see a patient and you see those features, what to think about. So a patient comes in, known history of CKD, correct? So and then family history, one of the questions that I mentioned in your history and physical to think about, family history of ESRD, and 2 uncles and female cousin. Also, the patient is of African descent, also has some risk factors, and physical exam and vital signs, yeah, could be normal, sure, but there's anasarca. It's a big red flag, with all the edema, peripheral and orbital as well, should raise some flags of nephrotic syndrome. And then lastly, the labs that I talked about that you should think about ordering, including total cholesterol, which is not typically ordered inpatient, but something to think about when you're ordering labs. Second question, 43-year-old woman comes to the office to discuss results of a kidney biopsy that showed focal segmental glomerulosclerosis, so they kind of give us the diagnosis here. She also has hypertension. Family history is significant for end-stage kidney disease in her mother, diagnosed at age 50 years, and her maternal uncle diagnosed at age 48. Her only medication is chlorthalidone. The patient and her family are of African descent. On physical exam, blood pressure is 134/86. Other vital signs are normal. BMI is 35. There's 1+ edema in the lower extremity. Labs, albumin is normal. LDL is 120, mildly elevated. Creatinine is normal at 0.9. eGFR is 84, not bad. And urine protein creatinine ratio is elevated at 2300. Which of the following is most appropriate treatment? Cyclophosphamide, high-dose prednisone, lisinopril, tacrolimus. What do we think? Just think about all the supportive care we talked about during the talk.
We have a B and a C.
Majority B or majority C?
Okay, raise your hand for B. Okay, C.
Okay, in this case, remember that you want to, for all of the FSGS, you want to think about the things you can modify the patient before you jump into high-dose steroids or calcium inhibitor. So it's been shown in literature, as I mentioned, that ACE, ARBs, and SGLT2, they are also first line for the decreasing proteinuria in patients. So you want to make sure you optimize them first before you start any other secondary treatments. All right, and in summary, I know this is a busy flow chart, but I also find that very useful in terms of summarizing how to approach the diagnosis of FSGS. Think about a patient coming to you, well, you did a good physical and history, and now you have the thinking of FSGS, then you order the necessary labs in terms of CMP or lipid panel urinalysis, then get nephrology on board. They did a kidney biopsy and have FSGS as the diagnosis. Then going back, if there's full-blown nephrotic syndrome, very severe, generally that's primary FSGS. Think about supportive care first in terms of ACE or of statins. Everything else you can modify before you jump to steroids, but steroids is first line, and if they don't, and that should be given for at least 16 weeks before they go into remission. And calcineurin inhibitors are the other ones, and that should be given for at least 4 to 6 months to build up in the system before remission can be assessed. And if there's no clear signs of nephrotic syndrome, that's where everything else come into play in terms of secondary FSGS. You rule out all these other causes. Do not find a cause, then make sure you do a genetic testing for that, and also undetermined cause come into play as well. The only other thing, you don't normally start with genetics testing, and that's something down the line after you've ruled out everything and confirmed primary FSGS. And make sure to always have a specialist on board whenever you start with FSGS, and because it is pretty important, and always evaluate the patient early on for renal transplant, if needed. Those are my references. Thank you.